Welcome to the Hospital Medicine Unplugged podcast.
Today we're doing a really important deep dive, I think, into managing febrile neutropenia, or FN. It's something anyone managing immunocompromised patients, especially in the hospital, absolutely has to get right.
Absolutely. Precision is key here.
Yeah.
And adherence to the guidelines from ASCO and the IDSA is critical, though they do evolve.
They do. And our goal today isn't just reciting guidelines. We want to get into the weeds, understand the why behind the high stakes of FN, unpack that rapid triage, the risk stratification tools, and importantly, how that ties into antimicrobial stewardship.
Yeah, stewardship is huge now, especially with resistance patterns. So maybe let's start with the basics, just to make sure we're all on the same page definition-wise. Not a lecture, but the nuances matter.
Agreed. So FN, febrile neutropenia, it's that combination, right? Fever, obviously. That's a single oral temp of 38.3 Celsius or higher.
Which is 101 Fahrenheit.
Right, 101 F. Or it could be a sustained temperature, say 38.8 Celsius, that's 100.4 Fahrenheit, for more than an hour. And then the neutropenia part.
And that's the absolute neutrophil count, the ANC, less than 500 per microliter. But there's that key addition, isn't there?
Yes, and this is crucial clinically. It also includes an ANC that's expected to drop below 500 within the next 48 hours.
That expected piece is so important for those high-risk oncology patients, the ones who show up maybe before they hit their absolute lowest point, their nadir.
Exactly, and that expected drop, or the current low count, drives the urgency. FN isn't just a fever, it's a true oncologic emergency.
Why? Because the risk is just incredibly high for things to go bad quickly.
Incredibly high, rapidly progressive infection, sepsis, organ failure, death. The data is stark. Any delay in getting those first antibiotics indirectly links to worse outcomes, higher morbidity, higher mortality.
We're talking significant mortality rates here.
Yeah, easily up to 11% in hospitalized adults generally, but much, much higher sometimes in hematologic malignancies, or if there's a delay getting treatment started. It can push past 25% in some studies for those really high-risk groups. Minutes matter, truly.
Okay, so the gravity is clear. Before we talk about fixing it, let's understand why these patients are so vulnerable, the pathophysiology and the common bugs involved.
Right. Understanding the why helps predict the what. It's essentially a triple hit to their defenses, mostly from the chemotherapy.
First is just the numbers game, right? Fewer neutrophils.
Exactly. Chemotherapy suppresses myelolipoisis in the bone marrow, so you get that ANC drop below 500. But it's not just any drop. The depth and duration are critical risk factors. Meaning profound neutropenia, an ANC less than 100, is much riskier than, say, an ANC of 400. And prolonged neutropenia lasting more than 7 days, that's a whole different ballgame, too.
You see that prolonged neutropenia often with induction chemo for acute leukemia or after a stem cell transplant.
Precisely. And those patients have a higher risk and often face different types of infections compared to someone with just transient neutropenia after solid tumor chemo.
So that's the lack of soldier cells. What's the second?
The walls are down. Mucosal barrier injury. Chemo causes mucositis inflammation and breakdown of the lining of the mouth, the esophagus, the gut.
Creating open doors, essentially.
Literal portals of entry. The patient's own gut bacteria, even fungi, can just walk right across that damaged barrier and into the bloodstream. That's translocation.
And that leads to the third problem. The body can't even signal properly.
Right, a blunted inflammatory response. You don't have the neutrophils to create pus or that really angry redness you'd normally see. So the fever might be the only sign that something serious is brewing systemically.
Which is why the physical exam has to be so meticulous, even if they look okay initially.
Absolutely. And it also explains why maybe in 2/3 of FN cases, we never actually find a specific bug. The fever could just be from sterile inflammation, cytokine release from the damaged mucosa or the cancer itself. Makes diagnosis tricky.
So when we do find a pathogen, what are we usually looking at? Does it change over time?
It definitely changes. Early on, or with shorter neutropenia, bacteria are the main players.
Gram-positives and gram-negatives.
Yeah. Gram-positives are still very common. Think coagulus-negative staph, Staph aureus, enterococci species, often related to central lines or skin breakdown.
But the gram-negatives are the ones that really scare us.
They are because they can cause rapid septic shock. Your usual suspects: E. coli, Klebsiella, and the big one we always have to cover empirically, Pseudomonas aeruginosa. Pseudomonas needs reliable coverage because it can cause really nasty deep tissue infection.
Okay, that's early on. What happens if the neutropenia drags on past that 7 to 10 day mark?
The landscape shifts, especially if they've already had broad-spectrum antibiotics. the risk of invasive fungi infection goes way up.
Like Candida.
Candida species, often translocating from the gut just like the bacteria, and also Aspergillus species, usually inhaled, especially in those high-risk leukemia or transplant patients.
And that risk dictates adding antifungals later, which we'll get to.
Exactly, and we shouldn't forget viruses either, particularly post-transplant. Respiratory viruses like flu or RSV, or reactivation of herpes viruses like CMV, EBV, varicella, they can definitely complicate the picture or even mimic bacterial sepsis.
Okay, that detailed background is crucial. Now let's get operational. The initial evaluation, that critical golden hour, speed and accuracy are everything here.
Everything. Triage has to be immediate. If a patient presents with fever and you even suspect neutropenia based on their history, the clock starts ticking right then.
And the guidelines are clear. 5 antibiotics within
60 minutes, 1 hour, max. And ideally, a physician sees them within 15 minutes of hitting the door. This isn't just paperwork, it saves lives.
So the clock's running. What's the essential workup we need to get done fast? History and physical first, obviously very focused.
Hyper-focused. You're hunting for subtle signs. Check the mouth carefully, mucositis, thrush. Scan the skin, any new rashes, cellulitis, or those dreaded ecthyma gangrenosum lesions suggesting pseudomonas.
And the perineal area.
Critical. A gentle inspection is usually needed, though maybe avoid a deep digital exam if platelets are really low. But you must ask about pain or tenderness there, because an abscess might not show much externally without neutrophils. Check catheter sites meticulously, too.
While that's happening, labs are being drawn. What's essential?
Standard stuff, but crucial. CBC with differential, of course. A complete metabolic panel check, renal and liver function. Serum lactate is key for perfusion status. Electrolytes.
What about inflammatory markers like CRP?
You can get it, but know its limits. In profound neutropenia, the CRP rise might be blunted. A rising CRP might be more informative than a single value, but it's not super sensitive early on.
Okay, labs drawn, microbiology, this is non-negotiable.
Absolutely non-negotiable. At least 2 sets of blood cultures. One set is aerobic and anaerobic bottles, critically important. One set has to be drawn from a peripheral vein, and one set from each lumen of any central line they have.
Why both peripheral and central?
If only the central line cultures grow something, especially quickly, it points strongly to a catheter-related bloodstream infection, which has specific management implications like line removal or lock therapy. If you only draw from the line, you can't make that distinction.
And volume matters for yield.
Hugely. You need 10 to 20 milliliters of blood per set. Underfilling bottles is a really common error that tanks your chances of finding the bug.
What about other cultures? Urine, sputum, CSF?
Only if clinically indicated. Don't just shotgun everything. If they have urinary symptoms, get a urine culture. Respiratory symptoms, maybe a sputum culture or respiratory viral panel, especially during flu season. Suspected meningitis, obviously an LP if safe. Stool cultures only if there's significant diarrhea or C. diff suspicion.
And imaging. Chest x-ray for everyone.
No, definitely not. Guidelines specifically recommend against routine chest x-rays in asymptomatic patients. Low yield, unnecessary radiation. Only image the chest if they have respiratory symptoms, hypoxia, or exam findings suggesting pneumonia.
But involve the specialists early.
Yes, get oncology involved quickly. They know the patient's chemo regimen, their expected duration of neutropenia. That's vital input for the next step, which is risk stratification.
Right. So antibiotics are ideally infusing or about to. Now we need to decide who needs to stay as a high-risk inpatient and who might be safe for outpatient management.
This is maybe the most impactful decision after starting antibiotics. Using validated tools to separate high-risk from low-risk patients is standard of care. It saves resources and protects low-risk patients from hospital hazards.
The main tools are the MESCC score and the CIS-ENI score.
Those are the 2 big ones, yes. The Multinational Association of Supportive Care in Cancer, or MASCC score, has been around longer.
How does MASCC work?
It's a score from 0 to 26. A score of 21 or higher generally means low risk. It looks at things like the burden of illness or symptoms mild or severe. Is there hypotension, COPD? Is it a solid tumor versus leukemia? Outpatient status when fever started.
And some factors weigh more heavily.
Oh, absolutely. Significant symptoms or hypotension basically tank the score immediately, pushing them into the high-risk category regardless of other factors. It tries to capture that overall clinical picture.
Then there's CIS-NE, the Clinical Index of Stable Febrile Neutropenia. How's that different?
CISNE is a bit newer, maybe simpler to calculate quickly. It's more of a binary tool focusing on 7 objective factors like specific comorbidities, if neutropenia is expected to last more than 10 days, severe mucositis. A low score like 0 or 1 points to low risk of complications. It has a very good negative predictive value.
Meaning if the CISNE score is low, they're unlikely to get really sick.
Exactly. It's good at ruling out imminent danger. But some clinicians feel MASCC is maybe better at capturing the gestalt, that overall sense of how sick the patient is, because it includes that subjective burden of illness.
So maybe a trade-off between objectivity and clinical intuition.
Perhaps. The key is using a validated tool consistently. And remember, most validation was in solid tumor patients. Applying them to, say, AML induction patients requires extra caution. Their baseline risk is just higher.
Okay, let's define that high-risk patient clearly. Who absolutely needs to be admitted for 5U therapy?
First, the nature of the neutropenia itself. Profound neutropenia, ANC under 100, or expected duration longer than 7 days. That includes your acute leukemia patients, intensive chemo regimens, stem cell transplants.
Second, clinical stability or lack thereof.
Any sign of hemodynamic instability, tachycardia, low blood pressure, poor perfusion, any evidence of organ dysfunction, kidney injury, liver problems, respiratory distress, and severe mucositis like grade 3 or 4 also puts them in the high-risk box because that barrier is so compromised.
Third, if you've already found a serious infection source.
Right. Clinical evidence of pneumonia, a complex skin infection, a definite central line infection, they stay inpatient.
And finally, other factors. Comorbidities, social situation.
Absolutely. Significant comorbidities, bad kidney or liver disease, uncontrolled diabetes, poor performance status bump up the risk. And practical things matter too. Can they reliably take oral meds? Do they have support at home? Can they get back to the hospital easily if things worsen? If the answer to any of those is no, inpatient care is safer.
Okay, now for the flip side, the low-risk patient. This is where we could potentially use outpatient management. What are the criteria?
They need to score well on the risk tools MASCC 21 or higher, or low-risk CISNE. Their neutropenia should be expected to be short, resolving within about 7 days.
And clinically?
Rock-solid stable, hemodynamically, respiratorily, neurologically, no signs of sepsis, no organ dysfunction, no severe mucositis, no obvious deep infection source.
And the logistical piece is key here too.
Crucial. They need reliable support at home, the ability to take and tolerate oral meds, understand instructions, and live close enough to return quickly if needed. And importantly, the guidelines recommend observing them for at least 4 hours after the first 5E antibiotic dose in the ED or clinic, just to ensure they remain stable before sending them home on oral meds.
That observation period makes sense. Catch any immediate issues. Okay, risk stratification done. Let's talk about the drugs themselves. Empiric antimicrobial therapy. What's the core principle?
Rapid administration of monotherapy with a broad-spectrum beta-lactam that covers Pseudomonas. That's the cornerstone for high-risk patients, or the initial dose for everyone.
What are the go-to choices for IV monotherapy?
The main options are cefepime, piperacillin tazobactam, or one of the carbapenems, typically meropenem or imipenem cilastatin. All provide good gram-negative coverage, including Pseudomonas.
Is one better than the others? I know there was a meta-analysis suggesting imipenem might have better outcomes.
Yeah, that network meta-analysis did show potentially higher odds of success without changing therapy and lower all-cause mortality with imipenem. But you have to interpret that cautiously.
Why cautiously?
Well, network meta-analyses have limitations, and the patient populations in the original trials might have differed. From a stewardship perspective, we generally prefer to start with cefepime or pip-tazo if possible.
To save the carbapenems.
Exactly. We want to reserve meropenem or imipenem for specific situations to limit resistance pressure.
So when do we reach for a carbapenem first line?
If the patient is hemodynamically unstable, clearly in septic shock, or if they have a known history of colonization or prior infection with resistant organisms like an ESBL producing E. coli or Klebsiella, in those cases, you need the bigger gun up front.
What about adding a second drug like an aminoglycoside? They used to be common.
It used to be, but guidelines strongly advise against routine double coverage now. Adding an aminoglycoside like gentamicin to cefepime doesn't really improve outcomes in most FN patients, according to modern data.
And it adds risk.
Significant risk of nephrotoxicity. These patients are often getting other nephrotoxic drugs or are already borderline. Adding an aminoglycoside without clear benefit isn't worth the kidney injury risk. Monotherapy is preferred.
Okay, the other big empiric question. Vancomycin for gram-positive coverage. Lines are common, staph is common. Why not add Vanket up front for everyone?
Stewardship, and lack of proven benefit for routine use. Vancomycin is not recommended empirically for most FN patients.
not.
Because most early bacterial infections, even many gram-positives, are covered by the primary beta-lactam. Routine vanc use drives resistance, especially VRE, and adds toxicity risk like nephrotoxicity and Redman syndrome without improving outcomes for the average FN patient. We have to reserve it.
Reserve it for whom specifically? What are the indications?
Clear, specific indications.
Yep.
1. Clinical suspicion of a serious catheter-related infection like pus at the exit site, tunnel infection signs. 2. Evidence of skin or soft tissue infection like significant cellulitis. 3. If they have pneumonia confirmed on imaging. 4. If they are known to be colonized with MRSA or VRE. And 5. If the patient presents in septic shock or is hemodynamically unstable, you might add it while waiting for cultures, thinking about potential MRSA toxic shock, but you'd aim to stop it quickly if cultures don't support it.
Makes sense. Now let's switch to the low-risk patient heading home. What's the standard oral regimen?
The standard outpatient oral regimen is typically combination therapy. A fluoroquinolone, usually ciprofloxacin or levofloxacin.
For the gram-negative and Pseudomonas coverage.
Right. Plus amoxicillin clavulanate for gram-positive and some anaerobic coverage.
What if they have a penicillin allergy?
Then clindamycin can usually be substituted for the amoxicillin clavulanate. But there is a huge caveat here for any oral regimen.
Which is?
Local resistance rates. If your local E. coli resistance to fluoroquinolones is high, say over 10–20%, then an oral fluoroquinolone RIB strategy might not be safe. Those patients might need to be treated as high-risk inpatients, even if their MASCC score is okay. You have to know your local antibiogram.
Crucial point. Okay, so initial therapy is started, risk stratification is done. Now we're into the dynamic phase. Modifying therapy based on how the patient responds. This requires close monitoring.
Absolutely. The first few days are key. Let's consider scenario 1. It's day 3. The patient still has a fever, but they're otherwise stable vitals. Okay, exam unchanged. What do?
The urge is often to add more antibiotics, broaden coverage.
Right, but that's usually the wrong move according to the evidence and guidelines. If they're stable, you continue the initial empiric monotherapy. Don't escalate just for persistent fever.
Why not? Doesn't the fever mean the antibiotics aren't working?
Not necessarily. Remember, fever can be from sterile inflammation, cytokines, mucositis itself. Adding more drugs in a stable patient doesn't improve outcomes, but does increase toxicity, cost, and resistance pressure. Patience is needed if they're stable.
Okay, scenario 2. The opposite. The patient was stable, but now they're deteriorating, getting hypotensive, new respiratory distress, worsening infection site.
That's an emergency. Escalate immediately. Broaden the coverage significantly. If they started on cefepime, now is the time for a carbapine. If they were already on a carbapine, you need to think about adding coverage for resistant bugs, vancomycin or linezolid for MRSA, maybe something for VRE, or even drugs targeting highly resistant gram-negatives like KPC, depending on risk factors and local patterns. The priority shifts from stewardship to saving their life.
Scenario 3. Persistent fever, still neutropenic, and now we're hitting day 4 to day 7.
This is the window where invasive fungi infections really start to become a major concern, especially in high-risk patients, the ones with prolonged, profound neutropenia, maybe on steroids, hematologic malignancy.
So time to add antifungals.
Yes. Empiric antifungal therapy is generally recommended at this point for those high-risk patients who remain febrile and neutropenic. You can't wait for proof. The risk is too high.
What antifungals typically?
Usually an azole with mold activity, like voriconazole, or an echinocandin, like micafungin or caspofungin. The choice depends a bit on whether you're more worried about candida or molds like aspergillus and local susceptibility patterns.
Is there a move towards using biomarkers to guide this, rather than just waiting for day 7?
Definitely. That's preemptive therapy. Monitoring serum markers like galactomannan for aspergillus and beta-D-glucan for many fungi every few days in high-risk patients. If those markers turn positive, you start targeted antifungal therapy then, potentially earlier or more accurately than just waiting for a specific day. It's a more tailored approach.
Okay, in the best case scenario, scenario 4, you get a positive culture back. You know the bug and its sensitivities.
That's when stewardship kicks in hard. Tailor the therapy. De-escalate. If the patient is stable and the bug is sensitive to a narrower spectrum agent, switch to it. Stop the broad empiric agents that aren't needed. This requires active review, usually by an antimicrobial stewardship team.
That leads nicely into duration of therapy. How long do we treat? It seems to vary.
It does. For the low-risk outpatient who responded well, it's fairly straightforward. Continue until they're stable. A febrile for 24-48 hours, and initial blood cultures are negative at 48 hours. You can often stop even if their ANC hasn't fully recovered yet.
But for the high-risk inpatient, the traditional approach was often to continue IV antibiotics until the ANC recovered, right? ANC above 500.
That was the tradition, yes. Keep going until the marrow recovers.
Oh.
But that's being challenged.
How so?
Recent studies, including some good randomized trials, suggest that in high-risk patients who are clinically stable, febrile, and have no documented infection source, you can consider stopping antibiotics earlier, even before full neutrophil recovery.
Why the change?
To reduce overall antibiotic exposure, limit C. diff risk, reduce selection pressure for resistance. It requires careful patient selection. They have to be truly stable and close monitoring, but it's a major shift towards stewardship, even in the highest risk group. Of course, if they have a documented infection like bacteremia or pneumonia, then the duration is dictated by that specific infection site and organism.
Makes sense. Okay, beyond the antibiotics themselves, what are the critical adjunctive measures and monitoring needed?
For the high-risk inpatient, supportive care is huge. Basic stuff first. Strict infection control. Hand hygiene is paramount for everyone entering the room. Appropriate isolation if needed.
What about using growth factors like GCSF during an FN episode?
Its role during active FN is still debated. GCSF is definitely used for primary and secondary prophylaxis, preventing neutropenia or preventing recurrence. Using it as treatment once FN starts is more controversial. It might be considered for patients with very severe infections, shock, or predicted very long neutropenia to potentially shorten the aeration. But strong evidence for mortality benefit is lacking. It's not routine for treatment.
And monitoring in the hospital.
Daily vitals, daily CBC, daily checks of kidney and liver function are standard. You have to be vigilant for drug toxicity, watching creatinine with vancomycin or aminoglycosides, adjusting doses because pharmacokinetics can be really altered in these sick patients.
And don't forget basic comfort and support.
Absolutely. Managing mucositis pain with appropriate analgesia and mouth care is critical for quality of life and potentially reducing translocation risk. Nutritional support is also vital to help them weather the storm.
Right, contrast that with monitoring the low-risk patients at home. How do we keep them safe?
It requires a solid plan and reliable patient caregiver. First, structured follow-up is essential. That means daily contact, at least by phone or maybe telehealth video, checking temperature trends, asking about any new symptoms.
And in-person checks.
Yes, a scheduled clinic visit within 48-72 hours of discharge is crucial to lay eyes on them, repeat labs if needed, and confirm they're still stable on the oral regimen.
Education must be paramount here.
It's everything. The patient and their caregiver need crystal clear instructions on warning signs, fevers coming back, developing chills or rigors, shortness of breath, dizziness, any new concerning symptom, and they need to know exactly who to call and where to go, usually back to the ED immediately if any of those things happen. No hesitation.
Okay, as we wrap up, let's quickly highlight some common pitfalls, things that can derail good FN management.
Pitfall number 1, the deadliest. Delaying those first antibiotics. Missing the 1-hour window. Processes have to be optimized to prevent this.
Number 2.
Incomplete source evaluation. Missing a subtle skin infection, not checking the perineal area thoroughly, or forgetting to draw both peripheral and central line cultures. You can't treat what you don't find.
Number 3.
Delaying antifungal therapy in high-risk patients. Waiting too long past that day 4-7 mark if they're still febrile and neutropenic. That's when invasive fungi infections take hold, and they are hard to treat once established.
And number 4 relates to stewardship at both ends.
Exactly. Stopping antibiotics too soon in a high-risk patient before they're truly stable, or unnecessarily escalating or continuing broad coverage in a stable patient just because the fever hasn't broken yet, both are common errors. Need to follow clinical stability and culture data.
So, to summarize the outlook, prognosis is very much tied to that initial risk assessment.
Absolutely. Low-risk patients, correctly identified with MSCC or CISNE, generally do very well. Mortality is often less than 5%. Outpatient management, when appropriate, is safe and effective for them.
But for the high-risk group?
It's a different story, especially those with leukemia, organ dysfunction, sepsis on presentation, or delays in getting antibiotics. Mortality can be substantial, sometimes, as we said, over 25%. Key predictors of a bad outcome include things like still being febrile after a week, profound neutropenia, kidney problems, or being tachycardic when they first present.
So the takeaway is rapid, risk-adapted management, coupled with really smart stewardship.
That's the current standard. And the final thought, looking ahead, is how we integrate newer tools even better. How do we best use biomarkers like galactomannan and beta-D-glucan routinely to shift from purely empiric to more preemptive antifungal strategies? And how do we refine protocols for safely stopping antibiotics earlier in stable neutropenic patients? Balancing aggressive initial treatment with careful de-escalation and targeted therapy, that's the ongoing challenge and where the field is moving.
An incredibly thorough look at a complex and critical topic. Thanks for breaking down the evidence and the practicalities of managing febrile neutropenia.